we did a study using a prospectively followed cohort of young women defined as under 40, or 40 and under rather, at time of diagnosis of breast cancer. And what we wanted to do was to look to see whether or not there were different long-term quality of life impacts of the different surgeries women have, specifically breast-conserving surgery versus a single mastectomy versus a bilateral mastectomy. And then we also wanted to look to see what factors might contribute to better or worse quality of life after breast cancer surgery. Aside from physical well-being, women who had unilateral or bilateral mastectomy had significantly worse quality of life outcomes in all of the 4 domains that we looked at as compared to breast-conserving surgery. And those specific domains were satisfaction with breast, psychosocial well-being, and sexual well-being. And this was using the breast-Q, which is a validated quality of life instrument that's specific to breast surgery. And then when we looked at the factors that predicted for quality of life after surgery, essentially, again, all those 3 domains, the satisfaction with breast, psychosocial well-being, and sexual well-being, undergoing mastectomy predicted for worse quality of life than undergoing breast-conserving surgery. So unfortunately, some women really don't have a choice for surgery as far as mastectomy versus breast-conserving surgery. Oftentimes, the addition of a contralateral prophylactic mastectomy is a choice. Outside of that, 10% of women who may have a genetic mutation in our cohort. So for the vast majority of women, they did have a choice. We also saw that the majority of patients, about 86% of the patients, were stage 0 to stage 2. Those are oftentimes women who have a choice. And so I think the impact of the study is just that we really need to talk more about not just the oncologic outcomes of surgery, which we know are equivalent for the most part, but much more about the potential long-term impacts of surgery, and that's something that we're just not doing right now. We wanted to figure out if all these women that are coming in and telling us that they're choosing bilateral mastectomy for peace of mind, are they actually achieving that goal? And we certainly get a sense for that in the psychosocial well-being, even though it's not a specific anxiety scale. Within this cohort, my senior author, Shoshana Rosenberg, has published on women with contralateral prophylactic mastectomy and their level of anxiety, and it appears that it might be a little bit lower, but we didn't necessarily do that same analysis in this cohort. But certainly the long-term impacts of surgery are long-lasting in that these women were an average of almost 6 years out from their surgery, and certainly there's concern that there may be a negative impact associated with the more aggressive surgery that more and more young women are having nowadays. The people enrolled, 86% of them had a college education or higher, and 80% of them reported that they were financially comfortable. So obviously there are concerns about generalizing that to everyone. I think what it does highlight, though, is that even that smaller percentage of women who was financially uncomfortable, they had worse outcomes in all of the domains that we looked at. So I think that really speaks to not necessarily the generalizability, but really the need to look at people who have lower socioeconomic status and why they have poor quality of life outcomes and how we can intervene to improve that. Well, I think ideally we have a shared decision-making model where the patient is sort of helping us figure out what their goals are and what their priorities are, and we're helping inform patients about what the long-term impacts are of the different choices, such that at the end, an informed patient is able to make the best possible decision for themselves, and hopefully this sort of information will help that conversation.